having a little look into lymphoma and various aspects of it. Let's have a look at the first question and let's see how we go from there on in. Okay. 1 minute. All right. Let's have a look at the answers. All right, let's look at.
So we have most people
the answers
voting
that
for D, and then we have
okay,
voting for C.
C at 30. All right. All right. Well, the answer for this question is about doing bone marrow biopsy and immunophenotyping C. So let's have a little talk about this and try and dissect this. So this gentleman's come in with very raised lymphocytes. He's slightly anemic, and his platelets are as well are a bit low. And the key question and the key thing here is that he's got lymphadenopathy and he's also got hepatosplenomegaly. So as soon as you see somebody who's got hepatosplenomegaly, if you go on to the next slide, then you need to be thinking of only a few key diagnoses. All right. So lymphocytosis can obviously be related, and we can see this in different infections. Predominantly, you can see these things, for instance, in things such as TB and things, and EBV and CMV. But realistically, in the setting of hepatosplenomegaly, there are only a few things it can be. All right, and the most common of these, aside from kind of hematological disorders, there isn't really that much. And the most common of these would be kind of CLL. Now, in terms of what the worrying features of lymphocytosis would be, then it's the fact that if you are finding any of the following criteria in bold. So if there's any signs that other cell lineages in the bone marrow are being suppressed, then this is concerning. Lymphadenopathy that is progressive, and when we say progressive, you want to see that there's usually significant bulky lymphadenopathy. So certainly with CLL, we've mentioned here that in this case there's cervical lymphadenopathy. They can typically get this bull neck, and certainly any B symptoms would make you very, very concerned. Now, in terms of what the overall diagnosis is here, if we move on to the next slide, then this would be a CLL picture, because this is the most common cause of a raised lymphocyte count in an over 80s. And whilst you really want to, what you want to do is, first of all, demonstrate that there is clonality between these lymphocytes. And a lymph node biopsy is important. You really want to demonstrate, as I said, that there is clonality there. And you need to ascertain the fact that there's been bone marrow invasion. This is kind of the most important part of it. You're trying to ensure that this is a bone marrow malignancy which is then spread. So immunophenotyping actually is one of the most important things to do. Now, CLL is one of these conditions where the lymphocyte count can become incredibly high. And unlike a lot of cancers, you do have time to actually just wait and watch. And we only realistically treat patients if they have significant lymphadenopathy, significant B symptoms, or if they have rapid doubling of their lymphocyte counts. So if you notice that the lymphocyte counts are doubling less than every couple of months, then this would be a reason to start treatment, because they're at high risk of things such as hyperviscosity syndrome, where basically the blood turns into treacle, and as a result, then get spontaneous bleeding. In this condition as well, it's very likely that they can develop autoimmune phenomena, so you can get autoimmune hemolytic anemias as well. And we can diagnose this condition and kind of stage it and things using what's called the kind of Rye or Burkitt staging, which is basically just depending on how much and how severe the lymphadenopathy is and its cause and its effects on the resulting bone marrow. Now, the blood film that you can see there is just typical, showing just some, you might see the blue kind of round cells throughout, blue round cells with kind of a little bit of clear cytoplasm in the surrounding. These are the kind of lymphoma cells that we can see, rather dense nucleus. So this is a typical picture of some CLL there. Now, as I said initially, you wouldn't actually treat a lot of patients. In this instance, you would, just because of the significant symptoms. But if you are going to treat, then some of the best things to do is to start off with some fludarabine, and you can also add in some cyclophosphamide or rituximab. But what we're finding more and more is that patients are needing newer treatments, such as venetoclax, which is a treatment which actually helps to block BCL, is it BCL? Sorry, I'm waking up, but BCL2, yeah, which is a key aspect of producing these leukemic cells. So, yes, what you really need to do in CLL is demonstrate clonality, and the most important means of that is immunophenotyping. All right, let's move on to the next question. For those type of questions, I'll answer them at the end. Actually, I don't, yeah. Some good questions. All right, should we see the answers from this one? History, right, well, that's perfect. So everyone's pretty much gone for A here, and that would be the correct answer in this instance. All right, so if you go on to the next slide. So when you read this, I mean, there's some frankly worrying features. He's got painless lymphadenopathy. It's painful after he drinks alcohol. This is a very rare feature, I will add, although I've used it just to really help with the issue. And then even the description of the bilobed large cells, that sounds like our typical nuclei that we will see in these patients. And here, yes, the key worry here is about Hodgkin's disease. So if we go to the next slide. But remember that when you're looking at somebody with lymphadenopathy who is young, you need to be thinking of particularly, obviously, the conditions such as SLE. You need to be thinking of things such as sarcoid. You need to be thinking of infections, TB, and always be thinking about HIV. So you need to always remember about these and any aspects of progressive lymphadenopathy, especially if it's generalized. So Hodgkin's disease, well, this is a malignant tumor, as we probably know, and this originates from B lymphocytes in the germinal cells of lymphoid tissue. And the characteristic thing is, as I've mentioned, these bilobed cells, which you can see on the bottom right, which are Reed-Sternberg cells, which are very, very specific for Hodgkin's disease, although you don't actually need them to make the diagnosis, of course. Now, in terms of when you break Hodgkin's disease down, its typical peak is in the kind of early 20s, and then there's a smaller peak in the over 70s. And we have basically different classifications, and the classical one you will see about whether there's lymphocyte rich, lymphocyte depleted, and nodular sclerosis. So nodular sclerosis is actually the most common type of Hodgkin's disease. So this is just a finding when you actually do the biopsy. Lymphocyte rich has the best prognosis and lymphocyte depleted has the worst. In non-classic Hodgkin's disease, this is the one which has a high risk of transforming into, unfortunately, a non-Hodgkin's lymphoma, so it will actually move. So if you move on to the next slide, typically when you see these patients, the key thing is that, remember, they often have significant cervical lymphadenopathy or supraclavicular, but they can also have severe mediastinal. So you always need to be making sure when you examine these patients that you look for any potential signs of superior vena cava obstruction, which would obviously present with your Pemberton sign. You may notice obviously conjunctival edema and also facial plethora and a fixed JVP, which you do sometimes see. As I've mentioned here about alcohol-induced pain, this is incredibly rare. So the crux of your diagnosis should not be based on this. It'll be based on you being able to see that obviously these patients have a high incidence of B symptoms, progressive lymphadenopathy, and that they have, for instance, the anemia and things that we can find with doing certain investigations. Now, what we know with Hodgkin's disease is that a lot of cases are present in HIV. So HIV it's kind of mandatory that you test this in these patient groups because they have about 5 to 10 times higher risk of developing Hodgkin. So you must do that. And whilst you're doing these bloods, you would also want to do an albumin and LDH because they have prognostic significance, as does if there's any anemia present. Now, I mentioned paraneoplastic syndromes on the top of the slide. There is a high risk with these Hodgkin's disease patients that they can form and have things such as cerebellar degeneration and peripheral neuropathy, and can actually present as a Guillain-Barré syndrome. So it's very important that you're aware that these are quite complex patients. Now, in terms of the key investigation for these, excision biopsy is very important for Hodgkin's, and what you want to demonstrate is this morphology in the lymph node of these Hodgkin's, these Sternberg cells. And EBV is basically something which basically increases the propagation of these abnormal lymphocytes, which is what lets them develop this phenotype. Now, staging here is with your ARBOR system, and we'll cover this later. But basically, treatment is kind of a fixed regime, whether you have the common ABVD, so this is looking at chemotherapy, so adriamycin, bleomycin, vincristine, doxorubicin, and some radiotherapy. Or if you're more advanced, then you have a very just a slightly altered regime of chemotherapy. But generally, these patients do have a good response, but obviously the major risk is ongoing cancer going forward. So let's move on to the next question now at this point. Okay, so we seem slightly split here. So the correct answer in this question is D. So looking at nucleated red cells and left shift. Now, if you remember for the options, you can kind of, this one is probably one to just slowly kind of go through, work out. But We know straight away he's 8, so that already tells us it can only be a few things. There aren't, for instance, when we say mature myeloid cells, I'm not expecting for him to have CML. He's in the wrong age group and things. And then our rods we know are basically inclusion bodies seen in blast cells, which we can see in AML. And once again, wouldn't expect him to be in that age group. Reed-Sternberg cells we know, as we've said, in Hodgkin's disease, and he's in the wrong age group for that. So really we know that it's either out of ALL at the top, or which is this leukemic lymphoblastic cells, or it's down below. Now, if we move on to the next slide, what we'll see is that ALL is usually something that occurs within 2 to 4 years old, and that usually presents with enlarged mediastinal lymph nodes, not this kind of appearance. And the key clue in this was the fact that he's African and he's got this fixed mandibular thing, and this is mandibular lymph node, and this is very, very kind of typical of Burkitt's lymphoma, which is a high-grade lymphoma. So this is, Burkitt's has 3 kind of main types. So we have one associated with immunodeficiency and is very much linked with HIV. We then also have HIV and immunosuppressive drugs. We then have sporadic, which is what occurs outside Africa and is associated with EBV, but to a lesser degree than the common endemic form. And in those instances, with the sporadic, you're more likely to form actually ileocecal lymphadenopathy. And then we have the endemic form. And this is the thing that occurs in equatorial Africa. So if you read somebody, a young kid from Africa with lymphadenopathy, you should be thinking straight away, this is probably Burkitt's. And this is a malignancy of children, and it is associated with chronic malaria and EBV, all right? And whilst it does affect the jaw, other things that you might see is other facial bones, and it can affect as well the kidneys or breast. Now, in this condition, there is a translocation between chromosomes 8 and 14, which, if you remember, is between the kind of IGH heavy genes and the c-MYC, which is why you get this constant production of these cells. And then we also have, in around 20%, a translocation between chromosomes 2 and 8. And as mentioned, a key thing here is that there's a real link between malaria as well, which works with HIV and EBV, to actually produce chronic B-cell stimulation and increase the risk of this lymphoma. And as the bottom right shows, the key thing here is that, what you really want to do is biopsy and PET, and that actually, if you start these patients on treatment, you will find that the lymphoma actually quite easily melts away. And what's very important is just starting treatment early. Now, what you can see when we look at that, the kind of lymph nodes and things, and the lymph and the blood film on the screen, you'll find that it's deeply blue, so deeply basophilic staining, and you get these very small vacuoles. If you can see around the edges, you get these small little white dots, which are basically lipid droplets, and this is very, very characteristic of Burkitt's lymphoma. All right, so if we move on to the next question, all right, but this is a typical case for Burkitt's. All right, let's have a... Okay, so it seems that the majority have gone for E, and that is correct. So obviously what we're looking at here is anal bore staging. And amiable staging is used for, if you move on to the next slide, is used for staging of Hodgkin's and disease and non-Hodgkin's lymphoma as well. It's a very simple system that's been around for effectively, well, it feels like forever. There is a modified amiable staging as well, but it's very important in providing prognostic information and helping clinicians to guide therapeutic decisions. But it doesn't, the key things that whilst it tells us the involvement of lymph nodes, it doesn't tell us, if there is bulky disease, for instance, and the significance of the lymphadenopathy at different sites. So basically, if it's only in one area of the body and it's a single lymph node chain or group, then you'd say stage 1. 2, if it's in two sides of the same side of the diaphragm. 3, if it's on both sides. And 4, then if it's actually now spread outside of the lymphatics. And then you can add different modifying factors. So B, all of us know about B symptoms of whether there's night sweats and weight loss, but actually you can use, for instance, X if there's a bulky disease of the mediastinum, which, as we've mentioned in Hodgkin's, can be very significant, presenting, as I've said, of vena cava obstruction. But also E, which is very severe kind of contiguous extranodal site from a chain, so immediately next to it now, maybe invading through to the skin, and involvement of the spleen as S. If we move to the next slide, so what I think is very useful is actually understanding the difference between, briefly, about Hodgkin's and non-Hodgkin's and how they present and things. So with Hodgkin's, one of the key concepts, as we've said, is this cervical lymphadenopathy. And typically what they do is you'll get asymmetric lymphadenopathy, but that will spread from contiguous, and will spread at contiguous lymph node groups. So they may get upper cervical lymphadenopathy, which then goes to the kind of posterior chain cervical lymphadenopathy, which then may spread to the axilla on that same side. Versus non-Hodgkin's, which is where you'll have symmetric, or you can have a more symmetrical involvement of your lymph nodes, but they will not spread to the next kind of location of lymph nodes. They may spread and they skip. So they might have one on the neck, and then you might move more into the groin, for instance. Now, as we've mentioned, with Hodgkin's, demonstration of the Reed-Sternberg cells is very important, and we can also have an involvement with EBV, as we've mentioned in Hodgkin's, whereas in non-Hodgkin's, the association with things such as HIV and, as well as this, autoimmune disease, so autoimmune phenomena, is very important. And with non-Hodgkin's, in a lot of cases, they will actually already have extranodal involvement as well. It's important to remember that non-Hodgkin's is much more common than Hodgkin's disease, okay? So it's about 5 times more common, occurring usually in people older than 50. And we can split these into whether they're low grade or high grade. So if something is low grade, this means that it usually has a very good prognosis. And survival is up to around 10 years. But what happens is that whilst you can really get on top of it initially, they're not usually curable in advanced stages. So initially can do well, but later on do less so. And for those, the primary ones are if it's a diffuse B-cell lymphoma, primary CNS lymphoma, and Burkitt's. And then high-grade lymphoma, what we're looking at is that you usually have basically worse symptoms on the first, when you see these patients initially, but actually they have, if you start them an intense combination of chemo, they have much better outcomes at this point. And in both these patients, but also non-Hodgkin's, we always need to be checking not only for HIV and things and EBV, we also want to check things as concurrent, Hep C, Hep B, and any Kaposi's virus, because you can get Kaposi's in these patients. And treatment here for those would be things such as R-CHOP, which all of us have probably heard of at some point. Okay, so with that in mind, let's move on to the next question. Okay, so most people are thinking phosphate for this, and yes, that would be a sensible thing. So obviously, whilst some of the other investigations may be useful in general for this gentleman, I mean, nobody would argue that in somebody with lymphoma, a CT is generally a good idea during the time that they have, their treatments, for instance. But here, he's giving clear signs of an overall disorder, if we go on to the next slide, of tumor lysis syndrome. And actually what we need to do is demonstrate the key findings of tumor lysis and its complications, all right? So what is tumor lysis? So this is something that occurs very frequently, actually, in patients who are being treated, especially for lymphoma. Remember, these cancers and malignancies are rapidly dividing, and because of that, they are more susceptible to the effects of chemotherapy because there's a more active proportion of cells which are obviously more susceptible to the chemo. And so what you'll get is massive cytolysis of these cells and release of the products into the systemic circulation. And the key findings are what we see on the left. So you'll get high potassium because obviously remember we only have about 5 millimoles of potassium in the plasma, most of it's in cells. High uric acid, which is through the same thing, but also it's a byproduct of actually cellular proliferation. And then phosphate as well is a key thing. And it is the phosphate which basically leads to precipitation of calcium, which is why you drop your calcium in these patients. And so you can see, for instance, tetanus in these patients when it's incredibly low. Now, it is important to note that whilst we do see tumor lysis in majority of kind of lymphoproliferative disorders, it can be seen in select solid tumors. It is rare, but it is seen, particularly in melanoma and some non-small cell lung cancer. But to diagnose this, you need to obviously see the key findings of these patients, which is, if we read the question, the patient was having reduced urine output, he's tachycardic, and he's feeling unwell. So these are the kind of key things, you should be demonstrating. Now, for clinical tumor lysis, we need to demonstrate that all of these kind of measures are about 1.5 the upper limit normal, or that they're developing arrhythmia. And what you should really do with these patients is obviously give them fluid. You need to treat the hyperkalemia. You need to be monitoring their urine output very, very carefully. And you want to stop any treatments that they may be on that contribute to the increased uric acid, which otherwise may precipitate forming stones, for instance. So these include things such as aspirin and thiazide diuretics. And then in terms of treatment for these patients, you want to use things such as rasburicase. Now, in order to help with overall prevention of this, because this used to be incredibly common, it is still seen, but it's usually now prophylactically treated, is that you give the rasburicase about 30 to 60 minutes prior to the chemotherapy in anticipation that this will happen. You can still use allopurinol, and in the acute setting, you can, but it works slower than rasburicase, and actually it's not really as good. So rasburicase is much better actually in this proven analysis. But certainly they can have quite severe renal failure. So dialysis is something that you may need to consider in this patient group. And in terms of the difference between allopurinol and rasburicase, in terms of mechanism, rasburicase is something that affects urate oxidase, and basically, whereas allopurinol affects xanthine oxidase. But there is one thing you should always be aware is with the rasburicase is that you need to screen for G6PD deficiency, because otherwise these patients, if you give rasburicase without treating and testing for that, increased risk of oxidative stress. So in the first instance, stop it, whatever drugs they're on that contribute to it, treat the hyperkalemia that they'll be having with calcium to try and help restabilize, and in the meantime, send off this test and start on some rasburicase. All right then. Shall we move on to the next question? I think this is the fastest I've ever been. Ooh. that? Should we have a little look? Okay, so D was radio. So most people have gone for radiotherapy here. So this is a good question because most people would feel unusual with the answer, but the actual answer here is C. So giving triple therapy with omeprazole, amoxicillin, and clarithromycin. So this chap has basically developed a mass in the antrum, and when you've looked at it, it's a bit odd because there's lots of lymphoid cells. So this is actually straight away, this is not a typical finding that you would expect in somebody with gastric cancer, and so this is straight away suggesting that there is a lymphocytic infiltrate and that this is likely lymphoma. Now, it also mentions in this test that he's got CLO positivity. So if we move on to the next slide, let's talk a little bit about it. So when we talk about MALT lymphoma, what we're talking about is the kind of mucosal associated lymphoid tissue. Remember, the body is made up of masses of lymphoid tissue through which circulating leukocytes can originate and stay in. So we have, obviously, we know about the tonsils, we know about the spleen, but one of the major ones is the MALT and things, with your kind of Peyer's patches and all this. Now, extranodal lymphoma, so i.e. lymphoma that is outside of the lymphatics, and more precisely extranodal non-Hodgkin's lymphoma, is very common, all right? And you can see this in actually a vast amount of patients, particularly in those with underlying autoimmune disease. So MALT lymphoma is seen very often with things such as Sjögren's syndrome. These patients are at high risk of lymphoma affecting the tear ducts and the glands. Now, in MALT lymphoma, one of the key things that is shown is that H. pylori is involved, and this is involved in the gastric type of MALT lymphoma versus other sites of MALT. And it's not all strains of H. pylori, because actually what we don't realize is that there are around 13 strains of it, but only one of which can cause this. And it's supposed to be as a result of B cell hyperstimulation and increased BCL2 expression. So the B cells are being constantly stimulated to proliferate, but because of increased BCL2, they no longer go through the methods of apoptosis. And as a result, they gradually acquire cytogenetic abnormalities. So you can find H. pylori infection in around 90% of gastric MALT lymphomas. And you may wonder, how do they present? Well, they present in the same way, with kind of alarm features, but vague, non-specific. And with these patients, you would kind of do the same things by, once you've got this biopsy, it's about doing bone marrow biopsies and doing immunophenotyping. And in terms of the kind of treatment, what is known is that if you treat the underlying H. pylori, then you can stop this, as I said, hyperstimulation of the B cells, and you can actually reverse the problem. Now, people do have chemotherapy as an afterthought, but even if you just give them their eradication therapy of H. pylori, you'd expect around 65 to 70% of cases to have a complete remission. Now, in terms of how it looks on endoscopy, the image on the right isn't brilliant, but usually it can present with either just simple erosions or usually as a giant vegetant ulcer, or in this case, thickening of the gastric folds. You can appreciate that the folds, you can see there, are quite thickened. So in summary, for this treatment, this is a very rare cause of kind of stomach cancer when you do it, but this is something which is probably one of the best prognoses. And actually treating the H. pylori can actually make a world of difference to their ongoing management and their prognosis. All right, so let's move on to the, I think, final question. Oh, is there one more to this? Oh yeah, sorry. Okay. slide. Should we? Fantastic. So here, the majority of people have gone for bleomycin, which is the correct answer. So let's just run through it. So we can see here that they've been treated with lymphoma. Okay, that makes sense. And then they've got widespread honeycombing in the lungs. So honeycombing is something characteristic of end-stage pulmonary fibrosis. So I would suggest that you look at an image of honeycombing because it's really stark and really impressive. And basically get thick-walled, air-filled cysts and septal kind of separations there. And the lung structure will be distorted, and you will get associated with this a classical find of traction bronchiectasis, because the fibrosed tissue is so much it actually pulls open and splints open the airways. Now, in terms of the distribution that we would expect with this kind of fibrosis, it's very important that you're aware of the etiology of fibrosis based on whether it's upper lobe or lower lobe. So with drugs, you were expecting a predominantly lower lobe fibrosis, okay? Other things you would expect in the lower lobe include idiopathic, as well as asbestosis. They would be classical, whereas upper lobe, you think of TB, ankylosing spondylitis, pneumoconiosis, and radiation, for instance. So in terms of bleomycin, well, what is it? So bleomycin is actually, it's a chemo that's produced by Streptomyces bacteria, and is basically used in Hodgkin's, non-Hodgkin's, and testicular cancer. Unlike a lot of these agents, it doesn't really cause major myelosuppression, immunosuppression. But one of the key things you need to be aware of is its effect on the lungs. And around in 10% of patients, you get bleomycin-induced pneumonitis, which is what is being described here. And basically, pneumonitis will lead to fibrosis. Whenever you hear pneumonitis, you're talking about fibrosis, basically. Now, in terms of what causes this, it seems to be multifactorial in nature, but it's thought that bleomycin will cause oxidative damage to the endothelial cells, will lead to the production of free radicals. And what we know is that actually, in the instance of when you give patients high-dose oxygen in the context of having previous bleomycin exposure, particularly in the first kind of 6 months, there can be basically you will get increased free radical exposure because the bleomycin will be kept in the lungs, and you will get this rapid change with these kind of typical chest X-ray findings of this lower lobe reticular nodular kind of change suggestive of fibrosis. And these patients will present with dry cough, shortness of breath, restrictive lung defect. Now, in terms of here, one of the key things is a lot of lymphoma patients receive kind of GCSF, and GCSF actually, if you remember, it stimulates the bone marrow, but actually what it will also do is it increases the survival of existing cells in the actual immune cells in the body, increases cytokine production, actually worsens the features. And if you look at the bottom left with the CT, you can see that there are progressive changes there with the lungs over the period of around 14 days. Now, I've said here about measuring the TLCO. So the TLCO is something which is a very useful measure, looking at the transfer of carbon monoxide across the alveolar membrane. And it's a very sensitive test, and will basically tell you if it's reduced. One of the key reasons is because you've got increased thickness now of the alveoli and the septations, you can't get that gas transfer. So this is a very useful way of monitoring patients who have bleomycin for the production of bleomycin-induced pneumonitis. Now, in majority of patients, we can give steroids and things to help, but supportive treatments are usually what's given. And if done correctly, especially if you start them then with high-dose methylpred, you can hopefully try and restore some normal lung function. Recently, agents such as imatinib, which you may recall is used in CML, have shown some promise in this arena too, although kind of formal trials are lacking. So let's move now on to the final question. And yeah, let's have a little look. I feel like I may have left a hint on that page. But... All right, let's have a look. Okay, so yes, I think my bold one actually may have given this. I apologize, but yes, warm autoimmune hemolytic anemia. So looking at the overall kind of thing, remember 2 months of new jaundice. Okay, fair enough. You know, gallstones could be, but the fact that there's a Coombs test that's positive tells you straight away this has to be an autoimmune hemolytic anemia. We've mentioned here as well some paroxysmal nocturnal hemoglobinuria. This, you know, this is something that actually I would suggest that you know about, but this is not usually, this is Coombs negative as a key kind of thing, and this is an acquired cause of forming destruction of red cells and paroxysmal kind of clots. So if you move on to the next slide, hemolytic anemias themselves, you need to always think, you can break them down and think about intravascular, extravascular causes and intrinsic and extrinsic causes. So when we talk about, for instance, intravascular, so is it happening within the actual, in the bloodstream? So usually there's autoantibodies or there's complement involved that's attaching to maybe a defective cell. So if we think of intravascular intrinsic causes, which usually go together, then we're thinking of things such as red cell membrane disorders. There's something wrong with the actual surface of the red cell, which flags it up, and so it's broken down early. So you get hemoglobinuria in the blood and into the actual hemolysis screen. Now, other things then with the hemolysis, do we think inside the actual bloodstream, but is it happening more likely in the spleen, the bone marrow, and the lymph nodes? And this can then be linked with usually extrinsic causes. So this is whether you've developed infection, which has triggered this, in which case you usually get what we call a cold autoimmune hemolytic anemia, or is this related to drugs? And something they don't really teach is that there are loads of drugs that can cause hemolysis, and they usually, in a lot of instances, they are antibiotics. So in intrinsic causes, the main thing is that this is the reticular endothelial system that is causing the breakdown of the drugs. It is not that there's typically circulating antibodies to it. And so with these patients, because it's broken down by macrophages, you form hemosiderin. So you'll get high hemosiderin in these cases, not the high hemoglobinuria that you get with intravascular and intrinsic cases. So a nice kind of nuance to it. If we move on to the next slide. So whenever you have somebody with lymphoma, there is a high risk that they will develop autoimmune phenomena just because of everything that's happening with the overall kind of immune system. And the important thing to remember is that there's a kind of bidirectional thing. So if you have a patient with an autoimmune hemolytic anemia, then around about 20% of them will go on to develop a lymphoma in their lifetime. Likewise, about 7 to 10% of lymphoma patients will develop an autoimmune hemolytic anemia. Now, we say warm because it's how best the actual antibody attaches to the surface of the red cell. So it happens better at temperatures over kind of 37 degrees versus cold. Cold is when it's less than this, and it's usually IgM that binds. And it's in those instances, particular things you worry about, things such as mycoplasma pneumonia, which classically causes a cold type. Now, in these instances with kind of warm, you always want to do kind of a hemolysis screen. And hemolysis screen is just looking for the effects of you breaking down red cells. So if you break them down, you would expect, because you're getting more heme produced and things, you'd expect more bilirubin, which will be unconjugated. So you can ask for a kind of split bilirubin level to look at how much of it is unconjugated. You'd expect to see a low haptoglobin. Haptoglobin, remember, is a protein from the liver that usually mops up free HB because and free heme, because remember heme contains iron, and iron is a good thing for bugs and things and causes oxidative stress. And then you also want to do an LDH. LDH will often be raised in these patients. Now, in terms of DCTs, that means direct Coombs test. So this is where you're basically looking for, are there any autoantibodies that attach to the red blood cells when you look down microscopes and you add Coombs reagent. And then, as we said, you can basically say if they're IgG, then this looks like a positive Coombs test, and it's more likely it's just warm autoimmune, whereas if it's not, then it's more likely to cold. Now, treatment for these patients is dependent on the diagnosis, but usually what you want to do is treat the underlying problem, and then you'll see that the hemolytic anemia improves. But what you can do is obviously start steroids, and steroids are used in lymphoma anyway. It usually helps melt lymphoma, but this should hopefully suppress the autoimmune phenomena that we're seeing. In patients who do not respond to this, then these are where you may consider doing things such as splenectomy for kind of steroid refractory disease, and in very severe cases where you're not really getting on top of it, plasmapheresis. All right, so that's overall, that's all the kind of questions. It's a bit of a run through of kind of heme lymphoma. Apologies for my maybe disorderly kind of presentation, but my email's on the next slide. So if there's any questions regarding this, then obviously